Good morning, good afternoon, and good evening, everybody, from whatever time zone you happen to be joining us from. I'd like to welcome everybody to our lap mentor simulator in surgical training, hands-on training. It's high fidelity VR, and this is being presented by Dr. Dimitrios Stefanidis from Indiana University, and this is their results of their case study. First, we'll go over some introductions of all the parties that will be involved in today's webinar. Then Dr. Stefanidis will go over the Indiana University School of Medicine and Department of Surgery insights. He'll go over how they're using their Surgical Skills Center and how the pandemic that we're all very familiar with has changed their learning capabilities and how they're approaching surgical education. Also, he'll get into more depth on laparoscopic simulation and how that's utilized in their program, as well as an introduction and a demo of our lap mentor, specifically the Nissen fundoplication and inguinal hernia modules. And then we will enter a Q&A session at the end. If you do have any questions, I would ask that you please enter those into the chat room, and we will address those at the end with Dr. Stefanidis himself. And also, if you are requesting any further information, pricing, demos, things of that nature, if you wouldn't mind entering those into the chat room as well with your pertinent contact information, email, facility, city and state, so we can direct those to the appropriate person to get back, to reach out and get in touch with you to get you the information that you need, that would be great. Thank you very much. Again, my name is Tom Barrett-Smith. I am the Regional Sales Manager for 3D Systems Symbionics Products based here on the West Coast. And my esteemed colleague, Guy Benisti, who is based out of our Littleton, Colorado office, will be doing the live hands-on demo from our office there in Colorado. It is my pleasure to introduce to you Dr. Dimitrios Stefanidis. He is a professor of surgery at the esteemed Indiana University School of Medicine. He is the Vice Chair of Education for the Department of Surgery. He is also the Surgical Director for the Skills Lab at the Indiana University School of Medicine. He's the Chief of Minimally Invasive and Bariatric Surgery, and his clinical interests include minimally invasive and bariatric surgery with a focus on revisional and robotic surgery. And his research interests include simulation, the reason we're all here, and education research and patient outcomes. And with that, I would like to turn it over to Dr. Dimitrios Stefanidis. Dr. Stefanidis, the floor is yours.
Tom, thank you so much for the nice introduction, and I welcome everybody to this session, and thank you for the opportunity to share some of our experience with all the participants in this session. So I'm just going to go over a little about Indiana University and the School of Medicine. So Indiana University has a combined student body of more than 100,000 students, and it is actually located in Bloomington, Indiana. However, the medical school of Indiana University, that has over 1,400 medical students, is located in Indianapolis at IUPUI, because in the 70s, IU, Bloomington, and Purdue, which is where in the map you see West Lafayette, joined forces, and they created a combined, essentially, university, which is based in Indianapolis and has specific disciplines located there. So the School of Medicine is mainly located at Indianapolis. So it is the largest school of medicine in the United States, and the way that is possible is by distributing the student body among 9 campuses across the state. So each year has approximately 360 medical students. So you see there's 9 campuses that are pictured in the image here. We have 5 basic science departments as well as 20 clinical departments. The School of Medicine also sponsors 99 ACGME accredited and 60 non-accredited residencies and fellowships in a broad range of specialties. We offer multiple PhD training programs as well as dual degree programs. Next slide, please. few things about the Department of Surgery. The department here consists of 6 divisions: general surgery, pediatric surgery, plastic surgery, transplantation, CT, and vascular surgery. And we have over 130 faculty members who work in 8 hospitals in the Indiana, Maine, and suburban region. And we also have 4 residency training programs in general surgery, cardiothoracic, plastic, and vascular surgery. There's also 11 fellowship programs that are listed in your slide that you can see. And in total, we have 101 clinical residents and fellows, as well as 14 research residents that participate annually in our program. Next slide, please. The Surgical Skills Center is accredited by the American College of Surgeons as a comprehensive education institute, and it's also designated by SAGES as a training site. We offer a number of curricula to all residency and fellowship training programs in the department, and we schedule sessions obviously throughout the year. Our trainees practice and receive immediate feedback on their performance. We use a variety of simulation, obviously, box trainers, VR simulators, as well as we also have sessions on porcine models and cadavers. Our residents have access 24/7 to a number of simulators, mainly the virtual reality simulators and the FLS trainer boxes that you also see pictured here. We have a Symbionics Lab Mentor, GI Mentor, as well as Angio Mentor, but we also offer ATLS, Asset, and Atom courses that are part of the curriculum and at no cost to our trainees. The CT surgery residents have also access to a kind heart cardiac surgery simulator. There's very few of these around the nation, as well as to some other simulators specific to their training needs. Next slide, please. So one of the aspects that I was asked to talk about is what changes happened with the pandemic. We all have had this experience, and we're continuing to live in these days. Hopefully that will come to an end soon enough for our sanity. But some of the changes we have to make to align ourselves with distancing guidelines. So the room occupancy, for example, in our main skills lab area was decreased from 30 to 20. When we do the cadaver sessions, we always wear N95 masks. And in general, we use that also in the vivarium, which is what is indicated here as the LARC facility, Living Animal Research Center is what this stands for. We have to move some courses farther down the timeline that we wanted to do to have more in-person sessions. And within the animal facility, because we do a number of training sessions there as well, we also are following distancing guidelines and making sure that we have all the protections necessary. Along those lines, of course, we also offered additional remote learning opportunities and additional didactic sessions that are offered via Zoom. And one second, please. So we also provided some portable trainers for our learners to take home with them to continue practicing on their skills, some open and some laparoscopic skills along those lines. We did revamp, as I mentioned, the didactic session. We added some new sessions. We did more corals, for example, with our residents to practice the cognitive decision-making skills. And we also used the benefits of MentorLearn, which is a way to follow your learners remotely in their progress in their training. Next slide, please. So as you can see, the impact that COVID-19 had on our program, you see in this graph, I've included a number of sessions that we have done over the years and in the sim lab for training, and the number of faculty members involved. And you can see we do have a big department, but we also have a large number of faculty who are engaged, individual faculty, which is great, about 60. But you also can see the impact COVID had as a number of the sessions dropped, and as well as the participating faculty, but we still maintained a fair number of sessions to maintain our educational goals for our trainees. Next slide, please. So how do we use laparoscopy in our program? As some of you who may know me, you know that I'm a big proponent of proficiency-based training. So this is clearly something that has been implemented throughout our curriculum, not just for laparoscopy, but definitely in laparoscopy. We do have so we do follow proficiency-based training for FLS, as many places around the country do. We also do verification of proficiency for specific procedures. This is some of the work that my current chairman, has done, Dr. Dunnington, who used to be at SIU. So we do, for example, check and ensure that our interns are competent in placing central lines, as well as doing chest tubes or cricothyrotomies, and a number of other tasks important for their level. But we also have a proficiency verification for some more advanced procedures. We have obviously procedural training. For that, we mainly use VR simulators or animal or cadaver models, which are all part of the training. We encourage deliberate practice. And for those of you who are not very familiar with what that means, is essentially practice that is driven by the learner. Their specific goals they set for themselves. They're trying to push their performance to the next level. There's feedback provided to them on their performance to identify any blind spots and help them improve. That way, and there's obviously also repetitive practice until those goals are achieved. Deliberate practice ties very well with proficiency-based training, and really makes the difference in bringing someone's skill to the next level. We do have semi-annual formal assessments that we test all of our residents to see how their skills progress. Not just in laparoscopy, it includes endoscopic and open skills. And we do have also a chief resident readiness assessment that we do annually. And that we focus that on the 4th years, because we want to have some time to intervene if there are any deficits, so we can build them up before they graduate the program. The chief resident assessment typically is on porcine models. We have them do specific 12 procedures that we're testing them on and checking them off. We also have developed a mental training and mental skills curriculum that aims at enhancing performance and optimizing performance under the variety of different conditions, like whether you're stressed or not, to always try to perform at your best. And that's something we are implementing at the beginning of training and during simulation and using simulation, because we want our learners to be able to learn those skills while they're practicing, because that's how we want to apply. We want them to apply during their clinical practice. Next slide, please. So I did want to also briefly mention to you a project that we have been involved in for the last 2-3 years, trying to bring our training to the next level of of making more competency-based. And now I'm talking about the whole residency curriculum, not just the skills curriculum in the sim lab. But I wanted to discuss with you how we have embedded the simulators as well as the skills curriculum within that bigger effort. So as a pilot study, and our paper is currently in press in the Annals of Surgery that's going to come out. What we did is we focused our efforts to develop a competency-based curriculum by focusing on one procedure. That's how we started. At this point, we have expanded to not just procedures, but also different services. But one of the main things we did and implemented was we said, okay, why don't we start with laparoscopic cholecystectomy? Laparoscopic cholecystectomy obviously is very common, commonly performed. Also in our program, our residents get a fair number of those, and per year they get about 20 typically. And we wanted to create a rotation where we can really use best practices in skills acquisition so that we can accelerate the learning curve. So what we did is we created the 1 month rotation that usually our second year residents participate. As a reminder, our second year residents, by the time they're second year, they've had already completed FLS training, so basic skills training. So we offer them, when they enter the rotation, we offer them cognitive training that includes SCORE modules. We also have them study the SAFE Lab Colli curriculum that has been developed by SAGES. This is essentially focusing around safe techniques during laparoscopic cholecystectomy with the main goal to minimize bile duct injuries. And we also offer them the FUSE curriculum. For those who are not familiar with this, the FUSE curriculum stands for fundamental use of safe energy. And it's also a product of SAGES. And SAGES is the minimum invasive surgical organization for laparoscopy, essentially. So, what the FUSE does, it really provides important background knowledge on the energy we use in clinical practice, whether that's the BOVI or the electrosurgery, really the way we should call it, and as well as ultrasonic dissectors, etc. So we have our trainees checked after they go through the modules to make sure that we give them essentially a cognitive test to make sure that they've understood and mastered the knowledge. And then we have them transition to skills practice. And actually, reality is a lot of this is happening concurrently. It doesn't have to be sequential for certain. So we have them refresh some of their FLS skills because they may have done the training several months prior. And then in addition, because it's specific to this curriculum, we have them practice on the lap mentor and do the laparoscopic cholecystectomy modules that include both practicing the different tasks of laparoscopic cholecystectomy as well as doing the actual full procedure. Along those lines, we also have a library of laparoscopic cholecystectomy videos that we ask them to review. And we also have videos that are specific to the surgeons who they're going to be doing the procedures with. So there's 8 surgeons who participate in this rotation, and they're located in different hospitals. So what the resident does is they check the schedule of the OR schedule the day before, and they go from hospital to hospital depending on where the lab calls are happening. And if there are no lab calls, they can engage in other cases and work with, or they can complete some additional training that they need to catch up with. So typically within the first week or so, we have accomplished these components, and from there on, and once they have, I forgot to mention that in the simulator, they have to meet specific goals for training. I'll refer to this in a moment and more specifically. So it's proficiency-based, so they have to meet those goals to be able to progress to the clinical experience. And usually our experience is within the first week, they'll be able to have mastered all this, because remember, that's what all they have to focus their attention to. And then they go from hospital to hospital doing the lab calls. And generally over the period of essentially those 3 weeks, maybe a little over 3 weeks, they get typically about 20 cases that they participate in. And as part of this, we record their cases. We have weekly sessions where one of us, the attendings, reviews some of the videos with them. And they bring the video, they discuss it, they identify specific areas in the procedure that they have questions about and they like some guidance, or we also provide specific feedback if we see something that we think is important to mention. We ask specific questions to understand, to make sure they understand important concepts around this procedure as part of, that has been also part of their learning and the cognitive part, the knowledge. So we use also OPRS and Simple. For those who are not familiar with these tools, OPRS is essentially a OSATs-based checklist that assesses performance, but is specific to laparoscopic cholecystectomy and goes over each individual skill. Part of the procedure. And Simple is an app that we use a lot in our program. And essentially, after each procedure, the resident generates a request for the attending on the procedure, and they do also self-evaluate themselves. But the attending also assesses the difficulty of the procedure, the performance of the resident, as well as the autonomy level. There's a collaborative group that uses Simple across, I believe at this point, close to 20 or over 20 institutions. And we've been one of the 3 that started this. So all these are ways to assess the performance of our trainees. By doing this, we're essentially, we also have the evidence how well this curriculum works, and the residents can see how they progress. Next slide, please. So we do offer, obviously, at the beginning of the rotation, we have a baseline testing, both for using the simulator as well as the first lab quality they do. We take we assess their performance, and consider that as the baseline. And then obviously we try to capture and video record the very last lab quality they do in the rotation to also be able to compare the change in performance. We do have, as you can see at the lower aspect of this slide, the average number that our curriculum residents, you can see that I mentioned earlier actually that they do about close to 20 on average laparoscopic cholecystectomies a year. We did use a historical control, which is the PGY3s. A couple of years ago, when we were implementing this, the residents who had just completed their second year of training, we assessed their performance to have something to compare to our newly trained residents with this curriculum. And that's what is referred to here as a historical control. At this point, we have 21 residents who've gone through this, and you can see that at the time of their testing, the post-test essentially, the PGY3s obviously were 2 years into it. The PGY2s, the average is 17 or close to 18 months, because as you might imagine, some of them, the post-test happens the first month of their second year, right? Because this is a 1 month long curriculum, and for some happens the last day of their second year. Next slide, please. So some of the data that we have acquired and have seen is that, for example, you can see here on the simulator, on the lap mentor, the laparoscopic cholecystectomy module, you see that the time at baseline, they went from 17 minutes to 8 being able to perform this. And that 8 minutes was very similar to the PGY3s that had done we had them tested at the beginning of the third year, the historical control I mentioned earlier. The time to extract the gallbladder is also dramatically lower, as you can see with training, the efficiency of cautery, etc. So the number of serious complications based on the laparoscopic assessment of the simulator significantly decreased. And you can also see the number of movements significantly improved, as well as the path length. When you look at the OPRS, which is the clinical assessment, essentially, when they're doing the actual procedures, you can also see the improvements that we observed from baseline to the post-test and how they compare to the third year. So you can see here that we've seen significant improvement, obviously, from the beginning to the end of this rotation. And the other thing we've been able to show is that this group of residents reaches a very similar level to in clinical performance and also simulator performance to those PGY3s who just had started. But the main difference being that we do this essentially at the end of the rotation after a month instead of a whole year. And yes, the average is essentially, the average difference is 6 months, if you were to look at it that way. But clearly, I think this is evidence that we can accelerate the learning of this procedure, at least based on this data presented to you for our trainees. Next slide, please. So the other interesting finding that we had is, so when we use the OPRS scale and we set that the benchmark for where we want them to be, to have the least skill, let's say, that we will be happy to, which we set as 3, kind of the middle of this rating scale, because 5 is like pretty much excellent, similar to an attending skill, etc. So you can see that even though before the implementation of this curriculum, our trainees were fairly scattered in their skill level. And I understand that that's a smaller group, but after the implementation, you can see that the vast majority, pretty much everybody is above that level of 3, which suggests that we're achieving the objectives of this curriculum. Next slide, please. So a few things about the lab mentor. As you know, here are several modules that exist currently and are pictured here. Including the laparoscopic cholecystectomy I was describing to you, appendectomy, inguinal hernia, ventral hernia, Nissen, gastric bypass, etc. Next slide, please. For the laparoscopic cholecystectomy specifically, the one that we also have embedded and included in this curriculum, we use it has modules where you can practice specific tasks like clipping, for example, the duct is shown on the upper right hand picture. And you can see also that they can practice the full procedure in the lower picture. And here there's complications that they may get into, like bleeding and how to deal with them, but it also has some elements of helping them with decision making of what to do. Next, please. And you can see the metrics that we used in our competence-based curriculum, and I presented some to you in the previous table, include the total time, the time to extract the gallbladder, the efficiency of cautery, the gallbladder perforations. As they remove the gallbladder, you can enter the gallbladder, and that counts as an error. The number of bleeding that hasn't been cauterized appropriately, serious complications. If you stick your instrument, for example, in the liver, that's recorded, and as well as motion-related metrics. And we use that for our proficiency-based training that I mentioned. We use expert levels for these metrics that actually have been published previously in the reference I've included from the Imperial College all over 10 years ago now. And we've refined some of those, but for the most part, we use what has been published before. Next slide, please. So a couple of things about mental learn. Many of you who are involved with simulation centers may be aware of similar solutions or with mental learn, but it is a nice way that allows you to have all the training data of your learners in one place that both the attendings can access as well as the learners can access. They can monitor their training. It combines all the data from all the different simulators of the Symbionics line, and it can be very useful also from a perspective. If you're a faculty member, you can go and check on your trainee and where they stand, so that you can know what the skill level may be before you work with them the next day. Next slide, please. And you can, as I mentioned, you can monitor the progress by looking at the specific metrics that we discussed previously and see where they stand and how they're doing and how to progress from there. Next slide, please. A few things about the Nissen fund duplication model. That's a new model that was developed, and actually we contributed to the development of this. We provided clinical expertise. Hopefully we helped with that, the Symbionics team, but it allows the dissection both of the crura, as is shown on the left side of the image here, as well as the taking down of the short gastric vessels, which are steps of the procedure that are important to learn. There's also complications that can happen and injuries that can happen that can be addressed, and trainees can learn how to approach this. Next slide, please. So here, I will turn it over to Guy, who will provide some demos, and I'll be available to answer any questions any of you may have when we're done. Thank you so much for listening.
Thank you very much, Dr. Stefanidis, and thank you, Tom, for the introduction. Hello, everyone. My name is Guy Benisti. I spent the last 20 years actually advocating and promoting simulation in medical education. I'm very proud to be part of this organization because I really do believe that simulators have a very, very significant place in medical education. I want to switch the camera so you can actually see the simulator itself. So this is the simulator itself. This is our Lap Mentor 3. This is a fully haptic system which contains pretty much all the features that Dr. Stefanidis just mentioned. We can connect a smaller Lap Express, which is non-haptic simulator, and thus allow the trainees the options of working individually on the simulator or work in a small team. Somebody will be the primary physician and somebody can be the camera assistant, or somebody can actually help with other functionalities during the surgery. Let me share the screen of the simulator itself. Okay, so as Dr. Stefanidis mentioned, the mentor learn itself is actually the envelope. Where is it? 1 second. There it is. So this is the mentor learn, the new version of mentor learn, where we are actually stepping away from Flash and focusing on HTML. Basically, the MentorLearn can come as an online version, as a MentorLearn Cloud, and can be offline, as in working physically with a simulator. Every student or faculty uses their personal credentials to log into the system. And once they're inside the system, trainees can go directly to their personal curricula. Faculty can go to the reports and view the training progress of their trainees. As Dr. Stefanidis mentioned, the simulator comprises of a very wide range of basic skills, where we focus on the most technical and surgical skills like iron coordination, depth perception, camera manipulation, soft tissue handling, electrocautery, and of course suturing, which are divided between basic and advanced suturing. And then we actually divided the simulator, all the training modules, as we call them, towards their groups. As in general surgery, we start off with a lap chole, then we move on to the appendectomy with incisional hernia, inguinal hernia, Nissen fund duplication, which we will see today, gastric bypass, colorectal surgery, nephrectomies, some basic GYN, and thoracic surgery procedures such as the lobectomy. So let me jump straight into the inguinal hernia and show you some of the work that we did so far in this beautiful module. First, we took this complicated procedure and kind of divided it into different tasks. So in each task, you can actually focus on, building your knowledge towards the procedure. So this is just an anatomical identification exercise. So the first thing that I actually have to do on the simulation is set up my camera. As you can see, it's got just a blurry image. And as I move the camera, nice and easy, I can take it all the way out, so I can actually see all the structures in the vicinity. And right now, the simulator is simply asking me to use one of my graspers. So here's my one grasper on my left, and then I have another grasper on the right. And it's just asking me to touch certain structures. So I'm just going to touch the bladder, and then it's asking me to touch the colon. So as you can see, they highlight. And then the umbilical ligament. Now, if I make a mistake, 1, 2, 3, The simulator will eventually highlight the right anatomical structures, and you can actually go and correct yourself. And you do this over and over again until you actually get the entire anatomy, all the ligaments, all the blood vessels, the triangle of doom, triangle of pain, and every other structure in that task. Upon completing the task, as Dr. Stefanidis showed you, is coming the performance report, which is very, very detailed and kind of measures everything that the student is doing. And thus it allows the trainee to get instant feedback, and then it allows the faculty to come back later and actually watch how the trainee was doing during his training. The second task is actually the incision dissection. So this is where things are getting a little bit more realistic, and now I have to very, very, very gently do the incision here without damaging any of the vital structures around that area. Of course, I can definitely injure and cut arteries and blood vessels, and I will have to cope with that. And if it's not a fixable problem that I created, I can always convert it into open surgery using this icon down here. Or if the complications are too much, then the simulator will literally convert it to open surgery by stopping the case. So there it is. As you can see, the graphic is extremely realistic. Tool selection menu, I have scissors here, but I was told today not to use scissors for the incision. So I'm just pulling the handle out, open, close the grasper. And this is my tool selection menu, and I can actually just slide across it and just find out exactly what is it that you want. In this case, I want the electrode. So I could have actually made a smaller incision. And one technique which I saw, which is actually very nice, that you can actually kind of mark, leave a little bit of a trace mark, so I can know maybe it's too low, maybe it's too high. The best part about simulations is that you can actually make mistakes and then actually try and correct them and do it over and over again until you actually get it right. In this case, I'm just going to try and create a tiny little incision here without actually complicating anything. So let me see if I can do that properly. So there we go. I'm getting the electrode a little bit towards the outside, pull it towards me a little bit, and very, very gently, I'm going to work myself into create this incision all the way above the hernial defect there. You have to be extremely gentle because I'm getting to the area where I'm going to hit some blood vessels. So it's very important that I actually pull it out, make sure that I don't.
Guy, what happened to your left hand? You lose it?
You're right, my left hand. So I'll take the actual multi-grasper, and I can, of course, grab the little flap and, of course, assist myself. Thank you very much for that, Dr. Stefanidis. It's that forum that makes me a little bit nervous now. And at this point, whether or not I'm exactly where I should be, that's not the point. Now I actually can change my instrument into a Kittner and very, very gently try to separate that flap. Nice and easy, just simply by working very, very slowly with the Kittner and try to expose the tissue, and very, very gently, just like that, peel it off. And this is a tedious task. I mean, it takes a little bit of time. You have to be very careful about the blood vessels that are hiding here. And I'm supposed, and there it is, peritoneal tear was recorded. So if I actually create any sort of complication, the simulator will automatically record it. And this will be part of my performance report, so I can actually learn a little bit better on what to do next time. And basically the task goes on until I completely release that flap all the way down below the hernial defect and try to do my best not to hit any vital structures on the way. As you can see, it works very, very nicely. You have to work very slowly. You can be a little bit more aggressive, but then you will have to pay the price if you injure. Even a peritoneal tear is considered a complication. So as you can see, nice and easy. I'm not in a rush to anywhere, so I'm just going to do it very, very nicely, because on the next stage, on the next task, after I'm done with that part, I'm actually supposed, I think I went a little bit too low in this area. And then I'm supposed to release the entire flap so I can actually put a mesh inside here and then tack everything together. As always, as soon as I finish the case, here's my performance. It measures everything from my hand motions, economy of movement, the distance, sometimes even the speed, how much time I was in idle time, which is why Dr. Stefanidis reminded me that, God gave me two hands, so I should actually use them, and I didn't. The camera was in the good. There was one peritoneal tear, which is not a big deal. We're not judging anyone. We just provide a lot of technical and objective information, and then the faculty should assess based on their benchmarks whether or not I did a good job. The last task, as you can see, this is actually broken into several parts of the full procedure, and this way they can focus on the smaller details of how to get it right. This is probably the more difficult task to me anyway, is to place the mesh and place all the tacks in the right place. So I'm going to do my best. Once again, we can go, and there it is. So the flap is completely open. So as you can see, there it is. Now, if I work individually, I can press the button on the camera and freeze the camera. I'm actually using a 30-degree camera. You can see my trocar configuration here with lateral right and left trocars, and then camera in the umbilicus. I have a mesh grasper on my right arm, and I have a meridian dissector on the right arm. Just before I actually move into the mesh placement, I want to show you a few of the features that we actually have. This is one of my favorite. We actually have an anatomical module, a three-dimensional map, which actually contains also automatic labeling. So if you actually want to teach the anatomical parts in that area and you want to show them exactly what to be careful about, so this is actually a very nice way to do this. Another option that we have is actually the movies or the guidance. In the guidance, actually, depending on the step of the procedure, so we have the mesh placement and the mesh fixation, we embedded through the inside the procedure, we embedded real-life videos of how to do this properly. Dr. Kukleta works out of Switzerland, is a global known expert in hernias. He helped us back in the day with the ventral hernia and the incisional hernia, and now he helped us with the inguinal hernia as well. He provides us with a lot of movies, so this makes our life a little bit easier when we try to simulate exactly what he's doing right now. So these movies are available for the students, for the trainees, and as they move to the mesh fixation, they can actually watch a movie if it's available, or guidance if it is available. So we can go back we can always have a full screen view, which is another option. So what I'm going to do now is, there is my mesh. I dropped it a little bit too soon. So what I'm going to try and do is bring it. You will excuse me if my technique is not very refined, but it is what it is. As long as I get that mesh inside and then cover everything, we should all be okay. So let me just push it through the hernial defect first, and then I'll stretch it a little bit. Dr. Stefanidis, I don't want to be judged on my technique right now. So with the other hand, of course, we can actually grab the flap a little bit and kind of push it towards the right corners, and here as well. So the mesh, I would probably want to put it a little bit to the right, if I can, but it's not critical. I think this is good enough. We got the entire hernia defect actually. So at this point, I'm going to use a fixation device. I'm just going to tack the mesh in 2 or 3 different spots right there on the bone, just to make sure that it's not going to move anywhere. Okay, and now comes the tricky part. So this is where I'm going to close the hernia defect. Hopefully I will get it properly, because that was a little bit of a struggle for me before, like right now. So this is a little bit challenging, but it is what it is. Okay, not a very smooth closing, but hopefully I can re-grab it and then re-tack it later on. You see, if I don't actually push that tissue hard enough into the top part, it will just not stay there. Okay, I know it's not a very good looking sealing of the hernia, but see, I'm not applying enough force to push that tack and leave it there. So, wasting too many tacks. Well, you know what? We can call it a day. What do you think, Dr. Stefanidis? Am I eligible to be accepted to the program?
I
There
have
we
to
go.
do my surgery on the simulator.
You stay in the virtual world, right? Number of movements indicate sometimes lack of efficiency because, as Dr. Stefanidis mentioned, you know, especially in surgery, the use of both hands is very, very important. Even though I'm pretty even on this case, but on the other case, I was definitely making much more movements with my right hand. So you can actually see the economy of movements. Looks like I did 10 tacks. I hope I got everything right. Only 7 of them were actually applied. So 3 of them were a waste. So you can actually see the smallest of issues when they happen. And by the way, every module is accompanied with a bunch of didactics. So you can actually see somebody else is doing the perfect peritoneal incision. So you can actually learn from them and then actually follow that, you know, the simulator itself. Sorry, it's not the simulation, it's actually the real deal. So, if you have any questions on the inguinal hernia module, you can obviously use the chat room and we will be notified if there are any questions for the general public. Otherwise, let me show you one of our latest addition to the simulator, and this is the listen from duplication. Actually, for many, many, many years, you know, people have been asking us for this procedure because it's a very it's almost a generic part of any surgical training, just like lap chole and appendectomies. Finally, we came up with this module. Right now, we have 2 tasks. One of them is the dissection to reveal the esophageal circumference and the crura, and then, of course, the division of the short gastric vessels. Before anybody asks, the fundoplication is actually a work in progress, so this will come out as the next part. As you can see at the bottom, we do have some didactics, so you can actually see a doctor do this in real life, and then you can try and apply whatever you saw into the simulation practice. So, once again, I am hoping not to make any mistakes. The best part about the simulator, or one of the best parts, is that you can actually manage complications. And if you actually, by mistake, nick an artery or you create a bleeding or something, you do have the ability to actually take an harmonic, for instance, and seal the vessel. So we just wait for the patient for the simulation case to load. And once again, there is my camera. So we start off right here, going through all this transparent tissue. You can actually see the pulsation, which is actually very nice. I hope you can see that. Yep. This is my trocar configuration. As you can see, the liver is already retracted. So I have somebody retracting the liver, and I have these settings. And without further ado, I have atraumatic grasper on my left, okay? And then I have the harmonic scalpel on my right. And I was told not to use the heel, but to try and grab it and put it away, and then now I can probably try and get it right. There we go. With small incisions, I'm pulling away the tissue so I will not touch the esophagus or hurt the muscle. The dissection here takes a little bit of time because I'm supposed to completely expose the crura on both sides of the esophagus. So this can actually be a little bit tedious. I mean, it does require a lot of attention to the small vessels or anything in the vicinity so you don't hurt it. Once you actually get there, you know, now I'm supposed to clean a little bit and try and mobilize the esophagus. And the way to do that, I can just open, close the grasper. As you can see, blunt dissection works beautifully on the simulation. We just get rid of this. It's right in my way. And it takes as long as it takes. You know, there's no rush in these procedures. There's no shortcuts. I really need to make sure that I completely mobilize and completely expose everything. So as you can see, opening and closing, I don't even need to use the I'm not supposed to use the electrocautery here, but I can definitely create complications if I'm not careful. So as you can see, there's my esophagus. You probably clear a little bit better on the crura, around the crura, but this is pretty much, you know, I can spend a lot of time now trying to clean the entire area and expose everything. But I think at this point, this is the first task. So first of all, expose everything, make sure that you see the muscle and you see the esophagus completely. And then we go into the next part, which is, again, the performance analysis, which is the division of the short gastric vessels. This is where team training comes very handy sometimes, because I can actually have somebody that will help me with the assisting grasper, as you will see in a minute. And when I work alone, I have a virtual assisting grasper, so that way I can add another instrument into the existing ports and make it a little bit more realistic and a little bit more. So first thing is the calibration, and then camera setting. So as you can see, I did not clean it as good as it looks right now, but this is what I was supposed to do. And now I go in here. I'm going to change my harmonic case for a second with an assisting grasper. I'm going to grab that flat of fat right here. And I'm just going to press the pedal, and it's going to freeze the instrument, and now I can go back with my harmonic. This is a beautiful virtual solution, you know, to the limited amount of. By the way, that lagging, that little choppiness that you see in the video is purely internet connection. It's got nothing to do with the simulation. The simulation functions in real time, as Dr. Stefanidis can attest to that. But right now, because we have a lot of people, you might actually see some lagging. But let's see if I can. Okay, I'm trying to be very, very careful. Not to, every time that you create a complication, there will be a big red sentence right above the screen, so you will not be able to miss that. Okay, I'm getting into the first vessel. Let's see where it is. Now, let me just change the camera view so we can actually see a little bit better. Get a little bit closer. Okay, I fixed the camera, which means I froze it. So because I'm working by myself now, I don't want to be holding the camera. Oh, I lost my instrument for a second. Triangulation skills are also important here, especially when you move into different parts of the abdominal cavity. A little bit of bleeders. There it is. There is the first vessel, so I can grab it. Then use the other pedal. There we go. I have to be very, very careful. I think I just grabbed the vessel. And there it is. Complication number one, an injury to the short gastric vessel was recorded. In order to control the bleeding, I'm supposed to find out exactly where did I actually leave that. So this is going to be interesting, because now that bleeding is going to start pulling, that blood is going to start pulling in the stomach. So what I can actually do is grab an irrigation and use the pedal, you know, for.
Hey, Guy, just wanted to give you a heads up. We've only got a couple of minutes left, and we have a couple of questions for Dr. Stefanidis that we need to.
Go ahead. I'm done at this point. You know, I just wanted to show some of the features.
Okay. All right. Hang on just a second. I'm going to go ahead and share my screen because we have one other announcement real quick as well. Okay. So just so you all know, let me get rid of that real quick. Sorry about that. On March 8th, we have a virtual launch for our Nissen and also our mesh placement. So for those that didn't get to see this, the link is there. And Our product director, Sophia, will actually post that in the chat room so you can grab it and cut and paste. So Dr. Stefanidis, we actually have a couple of questions for you. And I will just go ahead and you have your residents use the Lap Mentor first for FLS training and demonstrate some level of competence and then move to the FLS box trainer. That's the first part of the question.
So thank you for this question. So we don't necessarily do the virtual training first. We do them concurrently. So they both train on FLS as well as the Lap Mentor basic modules. But they need to have those skills first before they transition to the lap colic procedure and the more advanced procedures that the Lap Mentor offers.
Okay, and then the second part of that question is, could you also speak to how you were using the GI Mentor for FES training?
So yeah, thank you for this question. So very similarly to how I described the lap colic curriculum, we're doing the same with the FES training. So in other words, we do have a monthly rotation that happens to be also during the second year of our residency, which our residents participate in an endoscopy rotation. So they constantly work with 2-3 surgeons who do a lot of endoscopy and they get their experience with. And as part of that curriculum, they're also supposed to, we have specific modules from the GI Mentor that they're supposed to train with and complete. And in the end of that experience, we typically have them go for the FAS exam. Until recently, we had actually a project going on that we were allowed to as a part of a grant through SAGES, we had them take it also as a test to demonstrate the effectiveness of the curriculum. So they need to demonstrate proficiency in the specific modules that we have them do before we have them do the FAS exam at this point.
Okay, thank you. Next one we have is, so you spoke to about your competency-based education. How did you determine what benchmarks you were going to use when coming up with the system that you did?
So for the simulator was easy because as I mentioned, some of them are published. And if not, we develop them by having some of our experts perform the tasks and average their performance. For the actual clinical performance, this is still a work in progress from the perspective that, as I showed you, we define this as a score of 3 on the OPRS scale. But the next step we're taking is trying to define what a competent performance looks actually on the video. And we have a project going on currently trying to get some consensus from our surgeons to determine what that is. Because as I mentioned also, we do record the video of the procedure and we want to see if we can have a better way of assessing that competence. I hope I addressed the question.
Yep. Okay. And then I have another question here. Do the captured metrics in MentorLearn meet the needs you have in place for your competency-based training?
They meet, that's a good question. So they meet the needs from the perspective that we are maximizing the benefit the learners can get from the Lap Mentor, from the Lap Mentor simulator. What we have not necessarily looked at yet, but I'm sure it's something we'll be able to look at later when we accumulate more data, is we can see which of those metrics perhaps better predict clinical performance. That we haven't done yet, but that would be very interesting to see. And then we'll emphasize those metrics. Obviously, if some of the metrics I showed, for example, are out of the 8 metrics, if some of them are more better predictors of clinical performance, then obviously we'll focus more our attention to those. If all are predictive, then all are good.
Okay, and we've got one more here. It says, you mentioned goals, but are there a required number of hours of VR simulation? And if so, how did you determine this number of hours to be adequate?
Right. So a characteristic of proficiency-based training is that it's not really dependent on hours. It just depends on performance. So, and what happens typically is some individuals will get there faster and some individuals will get there slower. So we focus on the goals. So we just want to make sure they achieve the goals. We don't care how long it takes them.
Okay. And then I have one more here. It says, would you recommend the cloud-based MentorLearn?
I think it's very useful. I think what would be even better is if you could combine all the data into one from different types of simulators. But I think it makes your life, especially if you're involved in the administration of the curriculum, it makes your life a lot easier because it captures automatically the data and it presents them to you. And this requires a lot of labor otherwise, which we have to actually do for some of the other tasks, like even FLS tasks. You need to record the performance, you need to tabulate the performance, you need to create graphs so you can tell where people are. And that's already done automatically with something like the mentor learn.
Okay, that's all the questions that I seem to have. And I think we're almost out of time. So Olivia, did you have anything that you wanted or needed to add?
Nope, all set. Thank you, Tom, and thank you, Dr. Stefanidis, and thank you to Guy as well and all of 3D Systems Symbionics for an excellent presentation as always.